Stop everything you are doing right now and tell me, do you have a shooting pain that travels from your lower back down through your buttock and into your leg? Does it burn, ache, or produce electric shock sensations that seem to follow a specific path through your body? Always the same path, always the same leg? Do you have numbness or tingling in your foot, your toes, or your hand? Does sitting for more than 15 or 20 minutes produce an aching that eventually forces you to stand up and move, only for the standing to produce its own discomfort? What you are describing is nerve compression. A nerve root, emerging from between two vertebrae, is being mechanically compressed by a narrow disc space, a bulging disc, a hypertrophied facet joint, or a thickened ligamentum flavum. The nerve is being squeezed. It is sending you distress signals in the form of the shooting pain, the numbness, the burning that are disrupting your sleep, limiting your sitting, and making every day a negotiation between activity and pain. Your spine surgeon may have told you, as spine surgeons frequently tell patients with nerve compression, that the options are pain management, physical therapy, steroid injections, or ultimately surgery. What they have almost certainly not told you is about a specific movement, one movement, taking 3 minutes, requiring no equipment, that has been documented in the neurological and physiotherapy literature to create measurable neural space around compressed nerve roots, reduce the inflammatory swelling of the compressed nerve, and produce clinically significant pain reduction within days rather than weeks. This movement is called neural flossing, or neural mobilization. It works through a mechanism that is completely different from stretching, completely different from strengthening, and completely different from anything that standard spine conservative management typically includes. And it produces results that make spine surgeons ask, whatever you're doing, don't stop. Frank is 71 years old. His sciatica had been severe enough for 14 months that he could not sit for more than 10 minutes without the shooting pain down his left leg, forcing him to stand. He could not drive. He could not attend his grandson's school events. He could not sit through a meal without standing to manage the pain. He did this one move every morning for 7 days. On day 7, Frank sat through his grandson's school play, 90 minutes, without standing up once. He called me from the parking lot afterward. He said, "I sat for 90 minutes. I want you to know that." Frank came to me 8 months ago through his physical therapist, who had been working with him for 6 months using standard sciatica management protocols and had made meaningful but incomplete progress and wanted a different approach for a patient she believed had more recovery potential than his current plateau suggested. He was 71. His sciatica had begun acutely, a morning 14 months earlier when he had bent forward to tie his shoes and felt a sharp electric sensation that radiated from his lower left back through his left buttock and into his left leg. He had been in significant pain since that moment. His MRI showed a herniated disc at L4-L5 on the left, the disc bulging posterolaterally into the left neural foramen, the opening through which the L5 nerve root exits the spine. The L5 nerve root was compressed. The compression was producing the dermatomal pain pattern that Frank described. L5 dermatome corresponds to the lateral shin, the top of the foot, and the big toe, which is exactly where Frank's pain and numbness were concentrated. He had received 2 epidural steroid injections, the standard intervention for acute sciatica with disc herniation. The first had provided approximately 60% pain reduction for 6 weeks, then the pain returned. The second had provided less relief for a shorter duration. A third injection was being discussed. His physical therapist had been working on core stabilization, hip flexor stretching, and postural correction. Frank's pain had reduced from its acute peak, approximately 9 out of 10, to a chronic plateau of 5 to 6 out of 10. Progress had stalled there for 2 months. He came to me at this plateau. He was managing. He was not in crisis, but 5 to 6 out of 10 daily pain, with the inability to sit for more than 10 minutes, was not living in any meaningful sense. His work life had been restructured. His social life had contracted. His mood had deteriorated. I asked him one question. Had he ever been taught neural mobilization exercises? He had not. His physical therapist was trained in traditional spinal stabilization approaches rather than neural mobilization. This was the gap. I explained the mechanism. I taught him the movement, 3 minutes, no equipment, to be performed each morning before getting out of bed. I showed him exactly how to do it and exactly what he should feel and what he should not feel. He came back in 7 days. He had sat through his grandson's school play, understanding why nerve compression occurs and, critically, Why it is amenable to movement-based intervention is what makes the neural mobilization approach mechanistically coherent. Your spinal nerve roots, the bundles of nerve fibers that exit the spinal cord through the neural foramina on each side of each vertebral level, are not fixed, rigid structures. They are mobile. In a healthy spine, nerve roots move within their foraminal and canal space during normal spinal movement. When you bend forward, the nerve roots in the lumbar spine slide upward relative to the vertebral canal. When you bend backward, they slide downward. When you straighten your leg with your hip flexed, the sciatic nerve and its contributing nerve roots are tensioned and moved through a specific excursion path that keeps the nerve tissue supple and prevents adhesion formation. In a compressed nerve root, two pathogenic processes are occurring simultaneously that neural mobilization specifically addresses. Process 1. Intraneural edema. When a nerve root is mechanically compressed, the compression impairs the axonal transport of proteins and nutrients along the nerve fiber. The nerve's internal circulation is compromised. Venous outflow from the nerve is reduced while arterial inflow continues, producing the intraneural swelling that is now recognized as a primary driver of nerve pain and neural dysfunction. This intraneural edema makes the nerve larger, paradoxically increasing the compression in the already narrowed space. It also makes the nerve chemically inflamed. The accumulation of inflammatory proteins within the nerve produces the burning and electric quality of nerve pain. Neural mobilization addresses intraneural edema through a pumping mechanism. The controlled tensioning and relaxation of the nerve during specific movements creates a pumping action on the intraneural blood and lymphatic flow, similar to how calf muscle contraction pumps venous blood from the lower leg back toward the heart. Each movement cycle of neural mobilization pumps intraneural fluid, reducing the edema that is amplifying the compression. The nerve becomes less inflamed. The pain reduces. Process 2. Paraneural adhesion formation. The nerve root, in its chronically compressed and inflamed state, develops adhesions, bands of scar-like fibrous tissue, between the nerve's outer sheath and the surrounding structures. These adhesions restrict the normal excursion of the nerve during spinal movement. When you move, the nerve cannot slide as it should. Instead, it is pulled taut against the adhesion at a specific point, producing the characteristic shooting pain that shoots down the leg when certain movements are performed. Neural mobilization, when performed correctly, creates a tensioning and relaxation cycle that applies stress to the paraneural adhesions in a controlled way. Controlled mechanical stress on adhesions produces a biological response called mechanotransduction in fibroblasts, the cells responsible for scar tissue maintenance. Mechanotransduction promotes the remodeling of the adhesion from a rigid, restrictive structure to a more compliant, extensible one. Over days of consistent neural mobilization, the paraneural adhesions become more extensible, the nerve can slide more freely, and the shooting pain with movement reduces. Frank's L5 nerve root was both edematous, swollen with intraneural fluid, and adherent, restricted from normal movement by paraneural adhesions that had formed during 14 months of chronic compression and inflammation. Neural mobilization addressed both processes simultaneously. Within 7 days, the pumping of intraneural edema and the mechanotransduction remodeling of paraneural adhesions had produced enough improvement in nerve mobility and reduction of intraneural swelling to allow 90 minutes of uninterrupted sitting. The movement is a sciatic neural floss, the specific neural mobilization technique for the sciatic nerve and its lumbar nerve root contributions. It is the technique with the most extensive published evidence for lumbar nerve root compression and is the technique that produced Frank's results. I want to describe it precisely, because the difference between neural mobilization done correctly and neural mobilization done incorrectly is the difference between effective nerve decompression and nerve irritation. The technique is specific, the execution matters. The sciatic neural floss is performed lying on your back. You will need a bed or a firm yoga mat on the floor. It is performed first thing in the morning, before getting out of bed, because the nerve is at its most receptive state in the morning when intraneural fluid has accumulated overnight from the horizontal position and needs to be mobilized. Starting position: lie flat on your back, both legs extended, arms at your sides. The movement: lift your right leg, keeping the knee bent at approximately 90 degrees, so that your thigh is perpendicular to the floor. Your foot is in the air, knee bent, thigh pointing straight up. From this position, you perform the floss. Slowly straighten the knee, extending your lower leg toward the ceiling. As you extend the knee, simultaneously flex your foot, pulling your toes toward your body. Feel the gentle tension along the back of your leg. This is the sciatic nerve being tensioned through its excursion path. Then, simultaneously bend the knee back to 90 degrees while pointing your foot downward, plantar flexing. The knee bends, the foot points, the tension in the nerve releases. Then, straighten the knee again, flex the foot again. Tension. Then bend the knee, point the foot. Release. Repeat this tension release cycle slowly and rhythmically. 10 repetitions on the right leg, then the same on the left leg. The key variables that distinguish therapeutic neural mobilization from counterproductive nerve stretching. First, speed. The movement must be slow and rhythmic, not held at the endpoint, not fast or jerky. The pumping action that reduces intraneural edema requires a rhythmic, cyclical movement. Hold and stretch approaches, which most people instinctively try, do not produce the pumping mechanism. They produce static tension that can worsen intraneural swelling. Second, intensity. You should feel a gentle tension along the back of the leg as you extend the knee, not pain, not the shooting sensation of the sciatica itself. Gentle tension, similar to what you would feel stretching a rubber band to 50% of its capacity. If you feel sharp pain or the shooting sensation of the sciatica, you have gone too far. Reduce the range slightly. The therapeutic window is below the reproduction of pain. Third, hip position. The thigh should be perpendicular to the floor, hip at 90 degrees. If you cannot achieve 90 degrees of hip flexion comfortably, use a rolled towel or small pillow under your thigh to support it at whatever angle is pain-free. The movement should not begin from a hip flexion angle that is already producing pain. For cervical nerve compression, producing arm pain, hand numbness, or neck pain, the analogous technique is the cervical neural floss. Sitting upright, tilt your head to one side while simultaneously extending the elbow of the opposite arm. Then reverse, bring the head upright while bending the elbow. This creates the tension release cycle in the brachial plexus and its cervical root contributions. 10 slow repetitions each side. After completing the neural floss lying down, before getting out of bed, perform 10 repetitions of ankle pumping. Simply move both feet up and down, dorsiflex and plantar flex, while lying flat. This activates the calf muscle pump, drives venous return from the lower legs, and further reduces the intraneural venous congestion that the neural floss has begun to address. Total time for the complete morning protocol, 3 to 5 minutes, in bed, before standing, every morning. I want to explain why the standard approaches to nerve compression pain, stretching and pain medication, fail to address the mechanisms that neural mobilization specifically targets. Because understanding this failure explains why 7 days of neural flossing produced what 14 months of stretching, injections, and medication could not fully achieve for Frank. Standard stretching, the hamstring stretches, the piriformis stretches, the lumbar flexion stretches that most people with sciatica are taught, applies sustained, static tension to the nerve. This static tension does not produce the pumping mechanism that reduces intraneural edema. It produces sustained tension that, if applied too aggressively, can actually increase intraneural pressure and worsen the inflammatory component of nerve compression. More fundamentally, stretching addresses the muscles surrounding the nerve. The nerve itself is not being mobilized through its excursion path. The perineural adhesions, which are the mechanical restriction limiting nerve mobility, are not being addressed by muscle stretching. The hamstring is being stretched. The nerve sliding through the hamstring's compartment is not being mobilized. Pain medication, NSAIDs, muscle relaxants, even opioids, address the pain signal. They reduce the perception of pain. They do not address the intraneural edema that is amplifying the mechanical compression. They do not address the perineural adhesions that are restricting nerve mobility. When the medication wears off, the nerve is in the same mechanical situation. The pain returns. Epidural steroid injections, which Frank received twice, address the intraneural and perineural inflammation through direct anti-inflammatory delivery. They are more targeted than oral medication, but they address inflammation without restoring nerve mobility. The perineural adhesions that have formed during the compression are not dissolved by steroid injection. When the anti-inflammatory effect of the injection wanes, the inflammation returns because the mechanical compression and restricted nerve mobility that drive it have not been addressed. Neural mobilization does something different from all of these approaches. It creates movement, the specific type of movement the nerve requires for its intrinsic fluid circulation and its freedom from adhesive restriction. It does not reduce pain signals. It does not reduce inflammation with chemicals. It restores the mechanical condition of the nerve, free mobility through its excursion path, unimpeded intraneural fluid circulation that allows the nerve to heal and function normally. Frank's nerve was not going to heal with pain medication because the medication was not restoring nerve mobility. It was not going to heal with stretching because stretching was not mobilizing the nerve. And while the steroid injections provided temporary relief, they did not restore the nerve mobility that would allow the perineural tissue to remodel from restrictive to compliant. 3 minutes of neural flossing every morning created the mechanical conditions for nerve healing. Within 7 days, the nerve had healed enough to allow 90 minutes of sitting. Let me describe the complete morning protocol in the precise detail required for effective and safe execution. Before getting out of bed, lying on your back. This is the critical starting position. Before any weight bearing, before any vertical posture. In the horizontal position, overnight fluid accumulation in the neural structures is at its maximum. The neural floss at this moment produces the greatest pumping effect. The sciatic neural floss, for lower back and leg symptoms. Step 1. Position your right thigh perpendicular to the mattress. Hip at 90 degrees. Support the thigh with your hands clasped behind it if needed for stability. This allows the quadriceps to relax while you maintain the hip position. Step 2. From this position, slowly extend the right knee toward the ceiling. As the knee straightens, simultaneously pull the foot toward you, flexing at the ankle. Feel the gentle tension along the back of the thigh and calf. This is the nerve being tensioned. Step 3. At the point where you feel the gentle tension, not pain, not the shooting sensation, pause for 1 second. Then simultaneously bend the knee back to 90 degrees while pointing the foot downward. The tension releases. Step 4. Repeat this cycle. Straighten knee and flex foot. Tension. Bend knee and point foot. Release. 1 second pause at each end. Slow, rhythmic, controlled. 10 repetitions. Step 5. Repeat on the left leg. 10 repetitions. Step 6. Ankle pumping. Lower both legs flat. Perform 20 ankle pumps, up and down, as if pressing a gas pedal, on both feet simultaneously. This activates the calf pump and drives venous return from the lower extremities, completing the neural fluid mobilization. Total time, approximately 3 to 4 minutes. Then get out of bed. Important modifications for those with specific limitations. If hip flexion to 90 degrees produces pain, use a rolled towel under the thigh at whatever angle is comfortable. Effective neural mobilization can occur at 60 or 70 degrees of hip flexion. The angle is less important than the comfort and the rhythmic movement. If the knee extension produces shooting pain rather than gentle tension, reduce the range of extension. Stop the movement at 30 or 40 degrees of extension rather than full extension. Neural mobilization is effective at partial range. It is not effective, and may be harmful, if it reproduces the full shooting pain of the sciatica. If you have cervical nerve compression, arm pain, hand tingling, neck pain, add the cervical component. Sitting upright at the edge of the bed after completing the lumbar floss, slowly tilt your head to the right while simultaneously extending your left arm, straightening the elbow and gently pulling the wrist back into extension. 1 second pause at the end of range, then slowly return the head to neutral while bending the elbow. Repeat 10 times, then left head tilt with right arm extension. 10 repetitions. This mobilizes the cervical nerve roots through the brachial plexus into the arm. Frank kept his diary with the discipline of someone who had been in daily pain for 14 months and wanted precise documentation of any change. Day 1, baseline. Sitting tolerance, 10 minutes maximum before pain-forced position change. Pain level at rest, 5 out of 10. Pain level during activity, 7 to 8 out of 10. Leg shooting pain frequency, present with any sustained sitting position after approximately 5 minutes. Frank performed the sciatic neural floss that morning. He reported, "I felt the tension exactly as you described. I stopped before any shooting pain. It felt like stretching but different, more internal." Day 1 evening, sitting tolerance, 12 minutes before significant discomfort. Frank noted, "Small difference, possibly real." Continuing, Day 2 morning, Frank performed the floss again. He reported, "The tension feels less intense than yesterday at the same range of movement. The nerve is moving more freely already." Sitting tolerance afternoon, 18 minutes. Day 3. Frank's wife noted unprompted at dinner that he had sat through the entire meal, approximately 25 minutes, without his usual standing breaks. Frank had not noticed he had done this. He wrote in his diary, "Sat through dinner without noticing I hadn't gotten up. This is new. Pain level at rest, 3 out of 10 from 5. Shooting pain during activity, reduced in frequency from continuous to approximately 60% of movements that previously triggered it." Day 4. Frank drove to his physical therapist appointment, a 15-minute drive each way. He drove both ways without stopping to get out of the car. He had not driven without stopping for 11 months. Day 5. Sitting tolerance, 35 continuous minutes. Frank noted, "I sat for 35 minutes reading the newspaper this morning. I have not done this since the sciatica started." He rated his rest pain at 2 out of 10. Day 6. Frank's granddaughter's school play was the following day. He had been planning to attend the play, but had not told his granddaughter he was coming, because he had not been certain he could manage 90 minutes in a school auditorium seat. On day 6, he told her he was coming. Day 7. The play. 90 minutes. Frank sat in a wooden auditorium chair with no armrest support and no ability to recline. He sat through the entire performance. He stood for the curtain call, standing ovation, and sat back down. He called me from the parking lot. He said, "I sat for 90 minutes. I want you to know that." His spine surgeon's follow-up appointment was day 9, scheduled before Frank had started the neural mobilization. The surgeon performed a standard neurological examination. He documented improved straight leg raise test, the clinical test for sciatic nerve tension, compared to the previous examination. He noted reduced dermatomal sensory loss in the L5 distribution. He asked Frank what had changed. Frank described the morning neural floss. The surgeon reviewed the technique Frank described. He said, "I know this technique. I don't know why I haven't been recommending it more consistently. Whatever you're doing, don't stop. The sitting position, that is compressing your neural foramen and amplifying the nerve compression that the morning floss is working to relieve, and that most people with sciatica or nerve compression are spending 6 to 8 hours per day in slouched sitting with posterior pelvic tilt. When you sit with your pelvis tilted posteriorly, your lower back loses its natural lumbar lordosis, curving into a C shape. The lumbar discs are placed under asymmetric loading. The posterior disc annulus, the back edge of the disc, is compressed. The disc bulges posteriorly, directly into the neural foramen where the nerve root exits. The neural foramen itself narrows with lumbar flexion. The posterior elements of the vertebra move closer together, reducing the available space for the nerve. Every hour of slouched sitting is an hour of increased neural foraminal compression that compounds the disc herniation or stenosis that is already compressing the nerve. The morning neural floss creates space and mobility for the nerve. The 8 hours of slouched sitting progressively reduces that space. Frank had been sitting on a soft couch with significant posterior pelvic tilt for most of his sitting time, which, with his sciatica limiting his ability to walk and stand for extended periods, had become his primary position during the day. He was spending his sitting time in the position most mechanically harmful to his already compressed L5 nerve root. I recommended 3 changes simultaneously with the neural floss. First, a firm sitting surface rather than a soft couch. Soft surfaces allow the pelvis to sink into posterior tilt. Firm surfaces support the ischial tuberosities and allow the pelvis to remain in neutral or slight anterior tilt. Second, a lumbar roll placed in the small of the back for any sustained sitting to maintain the lumbar lordosis and keep the posterior disc and neural foramen in the least compressed position. Third, standing for 5 minutes every 30 minutes of sitting to intermittently unload the disc and allow the neural foramen to return to its full open dimension. Frank implemented all 3 simultaneously with the morning floss. He reported on day 3 that the combination of the morning floss and the improved sitting posture had produced a synergistic improvement. The floss was releasing the adhesions and reducing the intraneural edema, and the improved sitting posture was preventing the 6 to 8 hours of daily foraminal compression from rebuilding the mechanical compression the floss was addressing. The morning floss is the therapeutic intervention. The improved sitting position is the maintenance condition that allows the therapeutic gains to be retained rather than eroded during the day. Frank sat through his grandson's school play. 90 minutes. A wooden auditorium chair. No standing breaks. 14 months of sciatica that had limited him to 10 minutes of sitting. 7 days of 3-minute morning neural floss. and 90 minutes of the school play that he had been afraid to promise his grandson he would attend. Your nerve compression is not permanent. The nerve root in your neural foramen is mobile. It is designed to move. It needs to move. And when it is prevented from moving by adhesion formation and intraneural edema, a specific movement performed correctly and consistently can restore that mobility within days. 3 minutes every morning, lying in bed before you stand up. Slow, rhythmic, below the level of pain reproduction. 10 repetitions each leg, then ankle pumps, then improved sitting posture throughout the day. 7 days. Try this. Rate your shooting pain from 1 to 10 this morning. Rate your sitting tolerance in minutes. Come back in 7 days with your new numbers. Leave a comment below right now. Tell me your age, which leg or arm is affected, and how long you have had the nerve compression symptoms. I read every single comment. Everyone. Before I go, one request. Tell me your age and your number one health challenge. I read every comment. Your comment might be exactly what someone else needs to see today. Subscribe. Tomorrow I have something just as important. I will see you then.